Finals SAQ 84 Cerebral Palsy. An 8-year-old child with severe cerebral palsy is scheduled for an elective femoral osteotomy. A. Define cerebral palsy. This is a chronic disorder of movement and/or posture that presents early, i.e. before the age of 2 years old, and continues throughout life. CP is caused by static injury to the developing brain. Permanent damage to the developing brain may occur in utero, at birth, or during very early infancy. Functions affected are primarily motor. Other functions that may be affected includes cognition, sensation, and communication. There is increased incidence of impairments of vision, hearing, speech, learning, epilepsy, nutrition, and psychiatric problems. There is variable presentation, including spastic, dyskinetic, ataxic, and mixed presentations. B. List the clinical effects of cerebral palsy on the central nervous system, GI, respiratory and musculoskeletal systems with their associated anesthetic implications. CNS. Regarding epilepsy, ensure medication is not missed when new by mouth. Ensure anti-epileptic levels are checked if there is recent change in seizure frequency. Consider the impact of enzyme inducers and enzyme inhibitors. Regarding cognition or communication problems, there may be increased child anxiety. Involve carers and play specialists when appropriate. Consider individual need for sedative and/or anxiolytic-free medication, but caution if the child has respiratory compromise. GI issues includes increased risk of GI reflux due to swallowing difficulties, esophageal dysmotility, and abnormality in lower esophageal sphincter tone. Consider the need for RSI. Swallowing difficulty may lead to poor nutrition and low weight. Calculate drug doses and equipment based on weight, not age. Consider the possibility of anemia, dehydration, or electrolyte disturbances and treat preoperatively. There may be difficulty with oral medications. There may be risk of temporomandibular joint dislocation if affected by muscle spasticity, leading to possibility of difficult intubation. Prepare difficult airway equipment. A sleep fiber optic or video laryngoscopy may be indicated. There may be poor dentition, which may complicate airway management. Loose or decayed teeth should be managed in advance. Respiratory issues. Chronic lung disease may be caused by premature birth, GE reflux, and recurrent lung infections. Assess for acute respiratory infection and consider need for respiratory assessment, physiotherapy, treatment of infection. The child may require long-term oxygen therapy or CPAP. There may be increased risk of lung infection due to weak cough, respiratory muscle hypotonia, and reduced immunity due to malnutrition. Check and treat acute infection preoperatively. Long-term truncal spasticity may lead to scoliosis with resulting restrictive lung defect, pulmonary hypertension, cor pulmonale, respiratory and cardiac failure. Immobility may lead to inability to assess cardiopulmonary reserve. Musculoskeletal issues. Spasticity may lead to fixed flexion deformities and joint dislocations, difficult cannulation, monitoring and positioning problems. The thin skin, little subcutaneous fat, atrophic musculature causes the CP patient to be prone to have pressure sores, poor heat conservation, risk of hypothermia, poor wound healing, and need for careful padding and active warming at all times. It may be difficult to assess cardiopulmonary reserve due to immobility. Non-weight-bearing long bones become osteopenic, leading to bone fragility and risk of fracture. C. What are the specific issues in managing post-op pain in this patient? There is difficulty in assessing pain due to cognitive impairment and communication difficulties. The patient may be unable to use PCA due to muscle weakness or cognitive impairment. Opioid analgesia may lead to respiratory compromise. Painful muscle spasms may be precipitated by cold, anxiety, or pain. Treatment with regional nerve block or epidural catheters may be necessary. Continue regular antispasmodic medications. Renal impairment may be due to chronic neuropathic bladder or nephroureteric reflux. Avoid nephrotoxic drugs such as NSAIDs. Overall, 36.4% pass rate. Additional information on cerebral palsy with main reference ATOTW. Introduction. Cerebral palsy is a group of non-progressive disorders of motion and posture with a prevalence of 1 to 2.5 per 1,000 live births in the developed world. It results from injury to the developing brain during antenatal, perinatal, or postnatal period. Clinical picture is related to the area of CNS affected. Perioperative challenges includes optimization of respiratory function, GE reflux, seizure control, management of pain, muscle spasm, nausea, vomiting, and effective communication. Multidisciplinary management should be involved where possible, including pediatrician, surgeon, anesthetist, acute pain service, specialized nurses, physiotherapists, and speech pathologists. Understanding disease etiology, clinical manifestations, and management helps improve perioperative care of patients with CP. Etiology. CP results from injury to the developing brain, and etiology of CP is multifactorial. CP is likely the final common endpoint from a number of factors affecting early cerebral development rather than one specific event. Maternal, prenatal, or gestational risk factors includes long menstrual cycle, previous pregnancy loss, previous loss of newborn, maternal intellectual disability, maternal thyroid disorder, maternal seizure disorder, history of delivering child weighing less than 2,000 grams, history of delivering child with motor deficit, intellectual disability or sensory deficit, polyhydramnios, treatment of mother with thyroid hormone estrogen or progesterone, maternal seizure disorder, maternal severe proteinuria or high blood pressure, maternal mercury exposure, congenital malformation in the fetus, male sex of the fetus, bleeding in third trimester, intrauterine growth retardation, and multiple gestation. Perinatal risk factors includes prematurity, chorioamnionitis, non-vertex and phase presentation of the fetus, and birth asphyxia. Postnatal risk factors includes infection, intracranial hemorrhage, periventricular leukomalacia, hypoxia ischemia, persistent fetal circulation or persistent pulmonary hypertension of the newborn, kernicterus, hydrocephalus, trauma, and surgical lesions and their treatment. Etiology by age. In premature infants, CP is a common result of periventricular hemorrhages. For infants born after 34 weeks, factors contributing to CP includes brain maldevelopment, stroke, infections, or genetic disorders. Intrapartum hypoxia for term infants is now believed to cause only 6% of cerebral palsy. Classification of cerebral palsy. CP is commonly classified by characteristics of neurological dysfunction, such as spastic, dyskinetic, ataxic, and mixed, and extremity involved, of which classification includes quadriplegia, hemiplegia, diplegia, and monoplegia. According to the Swedish classification for CP, spastic is the most common clinical manifestation with 70%, dyskinetic 10%, ataxic 10%, and mixed 10%. Common surgical procedures involving CP child includes orthopedic procedures 60%. Examples includes multi-level surgery involving tenotomies, osteotomies, soft tissue release, tendon transfers, and botulinum toxin injections. Dental extractions and restorations 10%. Gastrostomy and anti-reflux procedures 10%. Imaging 10%. And other procedures 10%, which involves neurosurgery, urology, ophthalmology, ENT, and insertion of infusion devices. Clinical problems and comorbidities. CNS issues includes epilepsy, visual and hearing deficits, behavioral and psychiatric disorders, communication problems, and intellectual impairment. Epilepsy affects approximately 30% of CP patients, most commonly spastic hemiplegia type. Tonic-clonic and complex partial seizures are common. Normal anticonvulsants should be continued throughout the perioperative period. Understanding of anticonvulsant side effects and drug interactions are important. Visual and hearing deficits, behavioral and psychiatric disorders are common. ADHD is common in the higher functioning child. Depression and emotional lability are common in adolescents. These patients should be handled with care as communication difficulties may mask normal intellect. It is important to approach CP patients with sensitivity to allow time for effective communication with their carers. Communication aids may be required, such as sign cards or computer techniques. Intellectual impairment is common, however up to 60% of hemiplegic patients may have normal intelligence. Cardiovascular issues include difficult vascular access due to multiple previous cannulations, scars, contractures, communication problems, and behavioral issues. Chronic lung disease may lead to pulmonary hypertension, right ventricular hypertrophy, and cardiac failure due to call pulmonary. Respiratory issues include pulmonary aspiration, recurrent respiratory infections. Pre-op physiotherapy, bronchodilators, or antibiotics may be required. Chronic lung disease. Respiratory disorders are a common cause of death. Poor cough with retention of secretions. Poor nutritional state and impaired immunity. Scoliosis with associated restrictive lung defect and cardiopulmonary compromise. And difficult airway. Difficult airway is contributed by poor dentition, TMJ dysfunction, and positioning problems. The airway should be assessed for potential difficult laryngoscopy. Review of previous anesthetic charts may be helpful. GI problems includes GE reflux, which is common. This is due to esophageal dysmotility and spasm, abnormal lower esophageal sphincter function, and spinal deformity. GE reflux is difficult to detect. Night wakening may be the only indicator. Salivary drooling may be caused by pseudobulbar palsy, which may also occur with impaired swallowing. Tongue thrusting and poor head movements may contribute to difficult airway management. Poor oral feeding may lead to dehydration, malnutrition, failure to thrive, electrolyte imbalances, anemia, and poor immunity. Pre-op nasogastric feeding or gastrostomy may be required. Latex allergy has been reported in CP patients, probably due to multiple exposures during multiple operations. A history of latex allergy must be noted and managed accordingly. Medications. Medical therapy for controlling seizures, spasticity, GE reflux, constipation, and depression should be well understood, in particular with respect to adverse effects and potential interaction with anesthetic medications. Anticonvulsants. Carbamazepine. Mechanism of action is similar to local anesthetics, whereby it binds to voltage-gated sodium channels at the inactivated closed state, preventing cycling back to the resting state for the next action potential, leading to absence of sodium influx. Adverse effect of carbamazepine includes it is a strong inducer of CYP450 enzymes. There is reduced duration of action of drugs metabolized by CYP450 enzymes. Other adverse effects include bone marrow suppression, agranulocytosis, aplastic anemia, thrombocytopenia, Stevens-Johnson syndrome, drowsiness, ataxia, diplopia, hepatotoxicity, SIADH leading to hyponatremia and edema, teratogenicity, and avoid administering carbamazepine with MAOI due to structural similarity to TCAs. Mechanism of action of sodium valproate. It inhibits GABA transaminase and succinic semialdehyde dehydrogenase, leading to increased GABA and reduced excitability. Sodium valproate inhibits VGNAC. It increases neuronal potassium permeability, leading to hyperpolarization, and inhibits T-type calcium channel. Adverse effects of sodium valproate includes hepatotoxicity, impaired platelet function or number, bone marrow suppression, pancreatitis, sedation, ataxia, alopecia, false positive urine ketone, and teratogenicity. Antispasmodics. Baclofen. Mechanism of action, GABA B receptor agonist. Route includes oral or intrathecal pump. Adverse effects, sedation, confusion, apathy, vertigo, dizziness, ataxia, muscle weakness, nausea, urinary retention. Abrupt cessation may cause seizures or hallucinations. Problems with the intrathecal pump includes mechanical problems, reservoir infection with CNS spread, and abrupt withdrawal of intrathecal baclofen may result in hypermetabolic state with hyperparaxia, impaired mental status, muscle rigidity, rebound spasticity, rhabdomyolysis, and multi-organ failure. Potential interactions with general anesthetic drugs includes bradycardia, hypotension, and delayed arousal. Overdose of baclofen may lead to drowsiness, respiratory depression, rostral progression of hypotonia, and loss of consciousness. Treat with physostigmine or flumazenil, discontinue IT pump, and provide respiratory and cardiovascular support. Benzodiazepines are GABA A receptor agonists. Adverse effects includes respiratory depression, sedation, which is synergistic with other sedatives, dependence, and nausea vomiting. Adverse effects of oral dantrolene includes muscle weakness, dyspnea, malaise, nausea, diarrhea, skin rash, and hepatotoxicity. Mechanism of action of botulinum toxin is inhibition of release of ACH presynaptically. Issues includes dose-dependent reversible muscle denervation with or without atrophy if given long-term, mild injection site discomfort, fatigue and transient weakness of injected muscle, generalized weakness or systemic toxicity. Botulinum toxin may potentiate action of muscle relaxants and can unmask subclinical Eaton-Lambert myasthenic syndrome. Cisapride, which is a prokinetic, may prolong QT interval and increase the risk of torsade de pointes. Perioperative management. Preoperative considerations. Anxiety is common and may be exacerbated by poor understanding and communication difficulty. It is useful to have the primary carer with the patient at induction, in recovery, and during the post-op period. Parental anxiety and/or aggression may be manifestations of previous experiences, stress, frustration, guilt, or anger. Respect and good communication is vital in gaining cooperation and allaying patient concerns and fears. Consent for any procedure needs to be clearly informed. Risks and benefits discussed with the carer. Regarding pre-medications, benefits of sedative pre-medication should be balanced against side effects and potential unpredictable drug responses. Antacids and drying agents may be appropriate. Anticholinergics may be beneficial by drying oral secretions, but may increase the risk of chest infections by thickening lung secretions. Local anesthetic cream should be used at venipuncture sites to reduce pain and distress. Anti-reflux medication should be continued. Intraoperative considerations. Monitoring should be according to the national safety standard. Temperature monitoring is particularly important in cerebral palsy patients as they are vulnerable to hypothermia. Depth of anesthesia monitoring may be beneficial as MAC value is variably decreased. Neuromuscular monitoring is useful as CP patients have altered responses to muscle relaxants. Consider estimating endotracheal tube size based on weight. Beware of aspiration risk due to excessive secretion and reflux. Ensure adequate suctioning to clear excess secretions. Benefits of RSI versus gas induction in an uncooperative CP child must be balanced. Vascular access may be difficult. Use of ultrasound may not be possible in an uncooperative child. Two anesthetists is often helpful to establish IV access. Dehydration may be present due to abnormal cognitive responses to thirst and prolonged fasting and should be managed accordingly to achieve euvolemia. Positioning may be difficult due to fixed contractures. Perform extreme care to avoid nerve damage, muscle damage, and other pressure injuries. Hypothermia is common, which is contributed by disordered temperature regulation from hypothalamic dysfunction, lack of insulating muscle and fat, and malnourishment. Normothermia may be difficult to achieve despite use of forced air warming, warm IV fluids, warm irrigation fluids, and warm humidified gases. Drug responses are altered. Regarding volatile anesthetics, MAC is reduced compared to normal controls. Regarding muscle relaxants, there is resistance to non-depolarizing muscle relaxants, perhaps due to combination of drug interaction with anticonvulsants and chronic immobilization. There is slight sensitivity to suxametonium, but clinical significance is not determined. Neuromuscular monitoring in a severely affected limb may underestimate the extent of neuromuscular block. Avoid epileptogenic agents such as enflurane, etomidate, methotrexate, ketamine, petidine, and tramadol. Regional techniques are strongly recommended for intra and post-op pain control. Epidural analgesia is excellent for extensive lower limb surgery, however requires experienced operator as scoliosis and prior back surgery may make epidural analgesia challenging. Any regional infusion must be carefully monitored to avoid LA toxicity. Post-operative considerations. Emergence problems are common. Delayed emergence may be due to hypothermia and residual anesthetic effects. Irritability on emergence may be alleviated by presence of primary carers. Aspiration risk during the post-op period due to excessive secretion, regurgitation, vomiting, especially in children with pseudobulbar palsy, may complicate airway maintenance. Careful protection of airway and frequent suctioning is required. Post-op nausea and vomiting is very common. Antiemetics should be administered, particularly if opioids are used. Pain assessment can be difficult in the CP patient due to intellectual disability and poor communication. Behavioral indicators such as grimacing, groaning, moaning, altered sleep patterns may be present in the non-pain state and can be inconsistent and difficult to interpret. Hence, behavioral indicators lack sensitivity. The primary carer usually understands the child's personality and is an invaluable resource when assessing pain. Surgical pain must be differentiated from benign causes such as hunger, anxiety, and positioning discomfort. Treatment includes multimodal approach with epidural blockade, intrathecal opioid administration, other local anesthetic techniques, paracetamol, and NSAIDs. Systemic opioids may be given via patient-controlled analgesia or nurse-initiated analgesia. Any continuous regional or intravenous analgesic infusions should be managed in appropriate high-dependency unit to monitor for and treat potential toxicity. Specific problems includes respiratory complications, seizure prevention, severe muscle spasms, chronic pain, compartment syndrome, pressure injuries, and constipation. Regarding respiratory complications, perioperative chest physiotherapy will help those with poor cough, poor secretion clearance, and recurrent lung infections. Patients with poor respiratory function may need post-op ventilation and even tracheostomy. Pre-op respiratory function tests are unreliable and not predictive of outcome. Regarding seizure prevention, regular anticonvulsants should be continued. The patient may require IV anticonvulsants if oral intake is delayed post-operatively. Severe muscle spasms are frequent after lower limb orthopedic surgery. This may be due to spinal reflexes initiated by pain. Baclofen should be continued. Acute withdrawal of baclofen may lead to seizures and hallucinations. Diazepam may be given with appropriate ward monitoring until oral medications are recommenced. Beware of excessive sedation and respiratory depression when benzodiazepines are used with opioids. Chronic pain requires a multidisciplinary approach in its management. CP patients with normal intelligence may be suffering from depression and require appropriate treatment. Differentiation of surgical pain from other causes of pain is important as their treatment differs. Examples include hip subluxation causing pain on transfer, reflux causing night waking, back pain from prolonged sitting, period pain from menstruation, and painful spasticity. Regarding compartment syndrome, diagnosis may be delayed due to regional analgesia and impaired communication. To reduce risk of compartment syndrome, consider splitting plaster cast and leg elevation and constant vigilant observation. Pressure injuries may be contributed by fixed contractures, prolonged pressure over bony prominences, and malnutrition. Meticulous pressure care and frequent repositioning is required. CP patients are prone to constipation due to reduced gut motility and fluid intake, which is worsened by perioperative opioids, use of opioid-sparing analgesia where possible, and the prescription of laxatives may be necessary. These are my references. Thank you.